ये नहीं आ रहा, स्क्रीन नहीं आ रहा। Okay, good morning. Today we have lecture on the one of the important parasite, that is entamoeba, and its one specific manifestation, that is the liver abscess, and the topic for today is the amoebic liver abscess. Okay. So, in general, if you say amoebic liver abscess, it is caused by the parasite, that is the entamoeba histolytica, and this parasite is, if you we have already told you the classification of the parasites, it comes under the Amoebozoa phylum and the class is Rhizopoda. So, the motility in this class is on the basis of the pseudopodia. So, classically they are classified on the basis of the organ of locomotion. So, entamoeba, they have pseudopodia, they come under the Rhizopoda. Other notable parasites in this group, like free living amoebae, acanthamoeba. Okay. So, which cause? What does it cause? Acanthamoeba? Anyone? CNS infections हुए? No, not yet. Okay. So, acanthamoeba causes meningoencephalitis, a severe form of meningoencephalitis in which the patient almost always dies if it happens. So, in general, other genus in the entamoeba, intestinal particularly, are dientamoeba, iodamoeba, endolimax. These are certain genus which are found in the stool, in the intestine, and most of them are considered as commensal. They are non-pathogenic. Particularly in entamoeba also only pathogenic potential lies with the entamoeba histolytica and entamoeba moschkowski. Another one, a new entrant is Bangladeshi, which is not that it is not that much proven that it is a pathogenic one. So, entamoeba histolytica broadly, we have already covered the intestinal manifestation. So, it has two manifestations that are there. One is the intestinal infection, that is intraluminal infection, and second is the extraintestinal manifestation, wherein liver is the most common site of involvement. So, it disseminates through the portal vein and it causes the abscess in the viscera. So, most common is liver, it can go to other viscera also, but rarely. Second most common is lung. So, amoebic liver abscess can also sometimes extend to lung infection, and very rarely can go up to the CNS also and cause brain abscess, but it is very rare. So, entamoeba histolytica is a parasite which has been, since in the late 19th century it was identified. So, if you see, the first time Fedor Losch, he documented amoeba in the stool, and as of now it is a very important parasite. It is a parasite which traditionally has a worldwide distribution. So, initially industrialized countries like Europe and Americas, the burden was there, even in developing country, but they have now controlled it. So, as of now it is able to infect almost 50 million people in the world, resulting in around 1 lakh deaths in a year, and this is a very high burden of deaths due to this infection, and most of these deaths are due to amoebic liver abscess only. So, it is the second most common cause of parasite related mortality after malaria. So, if you can imagine how much is the burden of this infection. So, it is a very important significant infection. It is this kind of infection is more common in areas or communities where sanitation is poor. So, obviously downtrodden and in slum area, many cases in such kind of communities with improper sanitation and hygiene, you will find most of the cases. Okay. Geographically, it is now a problem, public health problem, mainly in the sub-Saharan Africa and the Indian subcontinent. So, in Indian context, it is very important for us to know about the amoebic liver abscess and its related differential diagnosis, because it is not that patient will come to you with saying मेरे को amoebic liver abscess है. The patient will come with some complaints, and there are other causes of liver abscesses also. So, you have to differentiate between those. So, in general of the parasite, if I tell you the life cycle, so the infection, it occurs due to the fecally contaminated ingestion of water or food. So, if the food or water is fecally contaminated, and this contamination due to Entamoeba histolytica cysts, and these cysts are usually hard to kill. So, even chlorination sometimes fail to kill the Entamoeba histolytica cysts. So, they persist in the water of food, and when a human ingests, it goes into the intestine, releases the trophozoites in the colon, and major site of infection in the human intestine is the colon. So, it infects colonic epithelium. There the excision happens, and from there it can either cause diarrhea or asymptomatic colonization. So, it is not that every ingested person will have the symptomatology. No, majority of the patients who ingest these Entamoeba histolytica cysts, they are asymptomatic colonizer, and this is how the parasite persists into the human for so long. So, they can either cause diarrhea, or the classical manifestation is the colitis, that is the presence with the bloody diarrhea and stool mixed with mucus and abdominal pain, lower abdominal pain. So, these are the features of the colitis. In less than 1% of cases, in around 1% of the cases, this parasite, where the trophozoites now has been released and is the major reason for the pathology, it goes through the portal system, portal dissemination into the liver or any other visceral organ. So, most common drainage of the intestine of the intestinal system is through the portal vein. It goes into the liver most commonly. From liver, it causes amoebic liver abscess, which can sometimes extend up to the lung, also causing lung abscess. Okay. So, this is in general the life cycle of the parasite. After colitis, trophozoites will get converted into the cyst, and these cysts or trophozoites, they are released into the stool. They are the diagnostic form as well. For we visualize them under the microscopy to diagnose a case, and also these go into the fecally contaminated water or food and cause the life cycle to persist. So, in general, this is the life cycle of this parasite, that is the Entamoeba histolytica. So, in simplified, ingestion of human contaminated water, excision in small intestine, but it migrates to the colon, and there colon, it causes the disease Entamoeba histolytica, which can cause invasive form of disease. What are the manifestation? One is the asymptomatic colonization, that is the most common. Second is the diarrhea, and third is the amoebic colitis, and then extraintestinal manifestation is liver abscess. So, in general, now Entamoeba dispar is these organisms, they look like, whenever we find in stool, we are not able to distinguish between them microscopically. You have to know that, especially those who are into diagnostic, they have to know that just seeing the Entamoeba histolytica cyst does not mean that it is Entamoeba histolytica. It could be Entamoeba dispar also, it looks same, and it is non-invasive also. So, patient may be having asymptomatic colonization and disease due to something else. Also, Entamoeba moschkowski, it causes non-invasive diarrhea. It does not have the potential to cause the amoebic liver abscess or even colitis. So, colitis is also uncommon with moschkowski. So, a kind of a mnemonic, if you can remember, a classical, that in general the 10% of the world population may be infected. It is called the 10% disease. 10% of the infected individuals, those who become infected, they become symptomatic. 10% of the symptomatic individuals will suffer mortality, okay, particularly with the liver abscess. And Entamoeba histolytica is the most pathogenic species among all entamoeba species. So, if you see the clinical manifestation, the most common clinical manifestation is not dysentery of entamoeba histolytica, it is actually the diarrhea, non-invasive the diarrhea that is without dysentery is the most common manifestation. It can progress to dysentery in few patients, but not all, and dysentery occurs in certain subset of these patients, but it is the most severe form of intestinal disease, where the patient complains of diarrhea and passage of blood with mucus and abdominal pain, particularly lower abdominal pain and pain while passing the stool, that is called as tenesmus. Okay. So, these are the most in general, आता है कि you have to differentiate between even in dysentery, amoebic dysentery and bacillary dysentery. So, as a one of the common feature of amoebic dysentery is that fever is not there and the disease is not that acute, whereas in case of bacillary dysentery, patient has got a very short history and patient presents along with fever, along with the intestinal manifestations. So, this is just for revision. So, topic for today is basically the amoebiasis, that is the liver abscess. So, if you see about liver abscess, that is the most common manifestation of entamoeba histolytica, invasive disease. Okay. And it is classically 10 times more common in men than in women. So, men, it has been observed that men are very high, you see the involvement of involvement of men with this disease. Okay. But and it presents with a classic triad of fever, right upper abdominal pain because of the liver abscess and hepatomegaly. So, that is very well as per the location of pathology. So, patient will have fever, right upper abdominal pain and hepatomegaly, and most of the time the right lobe of the liver is involved in case of amoebic liver abscess. So, this is there liver abscess. So, previously जो pain होता है, usually it is not very severe kind of pain, abdominal pain, it is a kind of a dull aching pain because there is pain in the abdominal viscera. So, previously when the imaging techniques were not there, यानी अब तो बहुत imaging techniques हैं, ultrasound, CT, MRI, all these imaging techniques, the diagnosis depends upon that. But previously when they were not that much in common, the patient usually came with the complaint of fever of unknown origin, fever of long duration, fever more than 15 days. Pyrexia of unknown origin is basically fever of more than 2 weeks, which is not getting diagnosed. So, अब तो कभी भी कुछ problem होती है थोड़ी सी भी तो we order, the clinician orders the imaging techniques, but classically it is a very important cause of pyrexia of unknown origin. So, if you see, this is a CT scan picture of this liver and showing the kind of a big amoebic liver abscess in the right lobe of the liver. So, usually diagnosis can be easily done by ultrasound, CT scan, particularly with contrast, and even MRI. So, CT in general, CT abdomen is the most commonly used and can be detected on the ultrasound, but CT is more sensitive. Ultrasound is relatively less sensitive, it cannot detect the small abscess. So, what are the routes of transmission for causation of the liver abscess? So, one thing is that one is amoebic liver abscess, you have to also think that there are other causes of liver abscess, and classically we differentiate liver abscess. कोई patient liver abscess का आता है वो तो उसको तो नहीं पता होता कि amoeba से है कि किससे है. So, there are other bacterial causes also for the liver abscess. Okay. So, that entity we call as pyogenic liver abscess, amoebic liver abscess, pyogenic liver abscess. So, what are the routes of transmission for overall? So, entamoeba histolytica के लिए through the portal vein. So, most of the amoebic liver abscess they occur because the circulation is through the portal vein. From intestine they can migrate to the liver and cause the infection. Then with हेपेटिक आर्टरी, एनी हिमेटोजीनस डिसेमिनेशन ऑफ एनी बैक्टीरिया, कोई भी डिजीज ऐसी जहां हिमेटोजीनस ब्लड स्ट्रीम के थ्रू बैक्टीरिया कैन ट्रांसमिट, कोई एग्जांपल दे सकते हो वेयर ब्लड स्ट्रीम के थ्रू इंफेक्शन कैन ट्रांसमिट? वेरी कॉमन डिजीज, तुम्हारे 3rd सेमेस्टर में पढ़ाई थी। ब्लड में कहां होते हैं बैक्टीरिया? परसिस्टेंटली बैक्टीरिया कहां ब्लड में कॉलोनाइज रहते हैं? नो, infective endocarditis, okay, they reside in the blood stream, no, at the wall, heart walls, so that is the blood stream. So like it can cause any hematogenous dissemination, it can through the hepatic artery can cause liver abscess. Then one of the commonest reason for liver abscess is also through the biliary tree. So any disease where there is inflammation of bile duct or gallbladder, that is the cholangitis or cholecystitis, that is for gallbladder, and cholangitis is of the bile duct, biliary tree. So it can cause the liver abscess. Okay. Then sometimes due to the contiguous infection, the infection is in the intestine, there is a abscess in the around the intestine, and it can go and directly infect the liver tissue. Then due to direct trauma or surgical iatrogenic, okay, कोई blunt trauma हुआ, penetrating injury, उसके बाद liver abscess, but these are slightly uncommon causes. Then if you see, there is another entity called as cryptogenic, where there is no predisposition, we don't know what is the reason for the route of transmission, and it is termed as cryptogenic route of transmission, where route of transmission, because there is no predisposing factor. So for liver abscess there has to be some kind of a predisposing factor, particularly cholecystitis, cholangitis, okay, or intestinal infection, okay, for amoebic liver abscess. Sometimes in the past, not immediately, but in the past patient may have suffered from diarrhea or dysentery, okay, recently, or at least in 1 year. So there has to be certain sometimes predisposing factor for causation of liver abscess. Intestinal infection, other kind of intestinal infections such as क्या क्या इंटेस्टाइनल इन्फेक्शन, कोलाइटिस तो हो ही गया एक तरीके का, और डाइवर्टिकुलाइटिस, ओके, इंटेस्टाइन में डाइवर्टिकुलाइटिस और एनी अदर कोलोरेक्टल कैंसर. So all these different intestinal conditions, they can predispose for the disease. So if you see the etiology wise liver abscess, one is the amoebic liver abscess entity, and then pyogenic liver abscess. So in general, particularly in the developed countries, pyogenic liver abscess is much more common, but in a country like India, almost both are amoebic liver abscess and pyogenic, they are almost equal, or maybe slightly amoebic liver abscess is slightly more commoner than the pyogenic liver abscess. What are the causes for pyogenic liver abscess? So enterobacterials most common, E. coli, Klebsiella and other enterobacterial members like Enterobacter, Citrobacter, all these can be the cause. Now one entity that we also find particularly in India and Madhya Pradesh also, the Burkholderia pseudomallei, that is milioidosis, we had taught you milioidosis. So that can also cause through the hematogenous dissemination, has a predilection for liver and abdominal viscera and cause liver abscess there. Then Pseudomonas aeruginosa also. Okay. So these are certain gram negatives which are common. Even gram positives can cause liver abscess, particularly intestinal, that is the enterococcus. The source is enterococcus का source क्या होता है? Intestine, नाम में ये entero, meaning present in the intestine. So this enterococcus and then sometimes Staphylococcus aureus, particularly infective endocarditis patients, they can, Staph aureus can cause liver abscess there. Then anaerobes. Anaerobes are also very important cause of liver abscess, and they should be ruled out, particularly the intestinal one, that is the Bacteroides. Bacteroides is a anaerobe, gram negative anaerobe, which is commonly present inside the intestine. So it is also an important cause of liver abscess. Fusobacterium, Clostridia perfringens. Okay, it is the source is intestine again. So, intestinal bacteria in general, if you remember the intestinal flora, they have the propensity to cause liver abscess, that is the pyogenic liver abscess. So, for amoebic liver abscess, what are the major predisposing factors? Male gender, chronic alcoholism. It has been observed that with chronic alcoholism, amoebic liver abscess is much more common, and maybe that could be one of the reasons, because male are more chronic alcoholic than women. Then sometimes steroid intake and certain MHC predisposition also. The association is that with HLA, this major histocompatibility complex, everyone has a different immune system. So, in one study and in few studies they have found that HLA DR3 जिनका होता है haplotype, they are more predisposed for having amoebic liver abscess. So, if you see the pathology, this is the. So, when you call amoebic liver abscess, one thing which very commonly is the association is that the color of the pus, that is the isolated from the aspirated from the liver abscess, that is the anchovy sauce pus. क्या होती है anchovy? What is anchovy? Yes, it is a type of fish. So, this fish, this pus just look like its sauce. So, it is called as anchovy sauce pus. So, if you see the liver color, it is almost that color. In contrast, जो pyogenic liver abscess होता है, उसका कलर क्या होगा? It is purulent, just like pus normally that we see. So, that way one distinction can be made, but amoebic liver abscess can sometimes be secondarily infected by the other flora also. So, ये कोई बहुत clear cut नहीं है कि amoebic liver abscess will always have this kind of pus. It is a very classical observation with amoebic liver abscess, anchovy sauce pus. So, if you have to work up, what are the investigation that you have to do in a case of liver, because patient doesn't come with amoebic liver abscess or diagnosis of pyogenic. It is we who have to diagnose the case. So, we have to investigate, we have to rule out take out the sample from the patient, and we have to do the investigations as such. So, what are the investigations for ruling out the amoeba? You have to, first of all, you have to take out the pus from the abscess. That is done under imaging, ultrasound guided or CT guided. Imaging karte karte, we aspirate, we put a needle, fine needle and a catheter and take out the fluid, drain the fluid. That is diagnostic as well as therapeutic. Treatment में भी वो काम आता है, क्योंकि पस अगर कहीं बॉडी में कलेक्ट होता है तो you have to understand that it has to be taken out. Okay. So, we have to do for amoeba, we can do microscopy, we can do culture of this pus for amoebic trophozoites. We can simultaneously see for stool routine microscopy. Almost a third of these patients are sometimes colonized with entamoeba histolytica cyst in the stool sample. Okay. Then we can do the serological test. I will come aage in detail. So, serology of particularly IgG and IgM antibody by ELISA for entamoeba histolytica specific antibodies. And then this test can also be done from the serum, that is the antigen detection. So, there is a particular antigen which is important in the pathogenesis, that is the lectin antigen. So, this lectin antigen can be used for diagnosis of amoebic liver abscess when done in serum. It can be also used for diagnosis of colitis, invasive colitis or diarrhea. In the stool sample also, this antigen can be detected and used for diagnosis. For pyogenic pus जो aspirate हुआ, we can take the gram stain, do the gram stain from it and see the bacteria. Then we have to do aerobic as well as anaerobic culture. So, we have to rule out the anaerobic bacteria as well, and then blood culture also, because the limitation is that क्या पस में से लीवर में से पस निकालना आसान है? Is it easy? It is not easy. It have its own complication. The pus also has to be, pus cavity has to be also big enough. so that you can attempt a percutaneous. Otherwise, it is a कैसा organ है? Vasculated organ है ना, so it can, patient can bleed also. So bleeding can be a complication. So we have to be very precise while we are draining. We cannot do blind puncture. Okay, blind aspiration we cannot do. So any aspiration has to be done under imaging. So most of the times, in few cases, you don't get the pus. So you are dependent upon other investigations such as blood culture, serology, or intestinal sample, stool sample, because these are easy to get. Such samples are easy to get. So if you see, so these are the common. Additionally, what you can do is that you can do the PCR testing from the liver abscess. Pus, if you are able to drain out, you can attempt the PCR, and it is one of the most sensitive techniques available for diagnosis of particularly amoebic liver abscess. One thing is that when you have to attempt the pus, when you are draining out the pus, what you have to remember is which form you have to see, which morphological form from the liver abscess, trophozoite or cyst. You have to see the trophozoite. Now, trophozoite identification is based on its motility. So, you have to see the motility immediately, otherwise you will miss the organism, because it will die out very easily, okay, in the sample, and then it will be very difficult to identify the parasite. So, one thing is that close coordination has to be done with the lab, okay, that we are going to drain out the pus and we will provide you the sample and see the examination immediately. Culture, if I tell you the culture, usually culture is done on egg based media, that is, this media is called as Boic and Drobalov media with a lock egg serum modification. Okay. So, it is a egg based media, a slant of egg is made and there is a balanced salt solution. You don't need to remember, just remember the name of this media, that is all, and remember that it is an egg based media. Any other organism where egg based media is used? TB, yes, very good. Tuberculosis, where you use the LJ media, Lowenstein-Jensen media. And another one organism more where egg based media, classical organism where egg based media, नाम में ही culture media के नाम में ही egg लगता है. Yes, which? Dorset egg media for Corynebacterium diphtheria. Okay, not that commonly used, but you can find it in book. So, okay, so in this kind of cultivation is called as xenic cultivation. This parasite cannot live without, when you are culturing this parasite Entamoeba histolytica, one thing you have to remember is that it cannot grow without the bacteria. Okay. So, that is called as xenic cultivation. So, in parasites, when you have to cultivate certain parasite, you have to give them certain bacteria. So, when we culture it on this, we have to, along with the sample, we have to add the bacteria also for it to multiply, to eat, because these are the food. Amoeba क्या खाता है? Amoeba तो bacteria cells वगैरह ये सब खाता है, ingest करता है. Okay. So, and we add rice starch also into the media for its growth. So, this is one of the histolytica parasite which is showing the trophozoite, which is showing the RBC, but its shape is not very defined because it is a trophozoite. It keeps on changing its movement. So, usually still photography is not of much help. What I will show you is that in the next slide is this. I have shown you this previously also, have I? Isme it is not moving, it will not work, probably the player is not there. So, if anybody is interested, they can contact me, I can show them on my laptop. So, this is a trophozoite, a live sample in our lab, we found this is the pseudopodial extension and it keeps on changing its morphology as it is moving around in the clinical sample, and these are the ingested RBCs. So, one of the major feature of the histolytica parasite is that a pathogenic trophozoite usually ingests the RBCs, one which has a pathogenic potential. It is not that other trophozoite cannot ingest, but more tendency is with entamoeba histolytica that you will find that inside there are ingested RBCs when you are seeing in the clinical sample. Okay. So, this is certain morphology, various shapes. So, what you have to think is that trophozoite has a varied shape. The shape can be like anything. Okay. This is slightly more a kind of a cystic, kind of a precyst, and this is a trophozoite having a single large big nucleus with a central nucleolus. These are certain cysts of the amoeba, and this is something called as chromatoidal bar. So, this is a fixed staining. This is not routine microscopy that we see saline and iodine mount. This is a trichrome staining, a fixed staining of the parasite trophozoite. So, what sometimes you may be asked about, what are the differences between the histolytica, trophozoite and E. coli trophozoite. So, if you see, this trophozoite is much bigger than the size of the cyst. So, usually the entamoeba histolytica cyst is around 10 micron. So, the trophozoite is much bigger as compared to the cyst, whereas E. coli trophozoite also it is bigger, but almost on the basis of size it is very difficult to differentiate the two. So, for coli trophozoite and histolytica trophozoite, one of the major feature for differentiation is that it has the ingested, E. histolytica trophozoite has a ingested RBCs. When you add trophozoite to along with blood, it will try to, it can ingest the RBCs. Coming to this is the lab diagnosis. Coming to the treatment part, how to manage. So, first of all, we have to give the antibiotics. That is the most common one is the metronidazole. Other options are tinidazole, ornidazole, these azole group of drugs for treatment. Okay. Drainage of pus, that is important, particularly if the volume is much more. If on CT scan, if the size of the abscess cavity is more than 5 centimeter, then we attempt a therapeutic as well as diagnostic aspirate. Otherwise, we treat with the antibiotics conventionally. Another reason for attempting drainage of pus is that when there is increased risk of rupture within the peritoneal cavity. So, it can cause peritonitis. Okay. So, what are the features? Large volume, if it is more than 5 centimeter, left or caudate lobe, because left lobe is relatively smaller in size, right lobe of the liver is much bigger. So, there is no risk of percutaneous rupture of the abscess. So, left or caudate lobe, and if it is near capsule or diaphragm sometimes. So, subcapsular, they have the risk of rupture. We have to follow up, give the treatment, follow up for resolution of the abscess. We have to follow up the patient after 2 weeks imaging, again repeated imaging to see that whether it is responding or not. If it is not responding, that you have to consider diagnosis for other. So, usually pyogenic liver abscess is not the topic, but you have to give when you are not able to sometimes reach a diagnosis, because diagnosis can only be reached in only 30 to 50% of cases, etiologic diagnosis. So, sometimes the clinician is forced to give broad spectrum treatment. So, combining metronidazole with a cephalosporin for antibiotics or a beta-lactam antibiotic with anaerobic coverage, because anaerobes are also there. Okay. So, dosage metronidazole, usually 10 days antibiotic if you give, it is sufficient to clear up the infection. 750 milligram given thrice a day for 10 days, or tinidazole if you can give 2 gram orally once for 5 days. followed by a luminal agent to clear up the infection from the intestine. You have to clear the infection because reinfection can also occur. Okay, so simultaneously we have to treat the intestinal infection. For this, the choices are paromomycin or diloxanide furoate. So these are the, in general, the amoebic liver abscess management. Okay, so now you can take the attendance. हेलो, अरे वो रिकॉर्डिंग बंद कर दो. हाँ, okay.
16, 17, 18, 19, 20, 21 to 30, 21, 2, 3, 4, 5, 6, 7, 8, 9, 30, 31 to 40, 31, 2, 3, 33, 34, 5, 6, 37, 8, 38, 39, 40, 41 to 50, 41, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51 to 60, 51, 2, 3, 4, 5, 55, 56, 57, 58, 59, 60, 61 to 70, 61, 64, 65, 66, 67, 68, 69, 70, 71 to 80, 71, 2, 73, 4, 5, 6, 7, 8, 9, 8, 81 to 90, 81, 2, 3, 4, 84, 85, 86, 87, 88, 89, 91 to 100, 91, 91, 92, 93, 94, 95, 96, 97, 98, 99, 101 to 110, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 111 to 125, 11, 111, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23,
previous batch to me कोई नहीं मेरे रिसर्च टॉपिक के बच्चे कौन कौन से कहाँ से